Good morning. Welcome again to Looking Back, Looking Forward, using evidence to inform sexual and reproductive health responses during the COVID-19 pandemic. Next slide. So this is a webinar that is being hosted by Studies in Family Planning and available on the Population Council platform. My name is Saumya, RamaRao, and I'm a senior associate in the Reproductive Health Program of the Population Council. Today, on this webinar, we are going to have presentations by Kristin, Bietsch, who you see on your screen, and then followed by Julia White, followed by Johannes van Dam, and Blanc, and I will, of course, serve as the moderator for today's webinar. Kristin is a demographer at Avenir Health, and she's part of the Track 20 project. Her interests are in the integration of service statistics and survey methodologies, as well as in male attitudes and use of family planning. She has a PhD from Princeton University. Julia White is from the Reproductive Health Supplies Coalition, where she is the Global Family Planning VAN Director. Global FP VAN stands for Global Family Planning Visibility and Analytics Network. This is an online platform that she has established, and the platform is useful for community members to share and use data on supply chains. Johannes van Dam is a senior scientist at PATH. He has over 30 years of experience working in public health and in operations research across 40 countries over 4 continents. He has deep expertise in HIV and AIDS and in infectious and neglected tropical diseases and a variety of reproductive health areas. And Blanc is the editorial chair of Studies in Family Planning. On today's webinar, what's going to happen is we will begin with a presentation from Kristin Bietsch, where she will talk about a recent paper that she and her colleagues wrote on the effects of the Ebola epidemic on family planning performance in Sierra Leone and Liberia. And this paper was recently published in Studies in Family Planning. Following Kristin, Julia White will talk about how data from the Global Family Planning VAN can be used along with data from the commodity gap analysis to figure out how disruptions in commodity supplies can be managed. Johannes will then offer some reflections, and at that point, we will open up for an interactive Q&A with you, the audience, and we hope that you will be sending your questions and comments in the chat box, and you will let us know to which particular presenter you want your comment to be or question to be addressed to, and that's where we will have a nice interactive dialogue going. At the end of it all, Anne will offer some closing comments, and the 1 hour will be done at that point. So, without further ado, let's get rolling. So where we are right now is, as all of you, I'm sure, we've all been having discussions about the effects of the pandemic. COVID-19, as of data from yesterday's Johns Hopkins University. So what's happening with the pandemic is that there are over 3 million cases globally and over 200,000 people dead. And clearly, the health systems are finding it a challenge to address not only the management of COVID-19, but providing the range of services, health services that normally health systems do. And we're also beginning to see the effects go beyond the health system, and we're seeing economic effects as well. So this is the context in which all these conversations are having place. Now, let's talk about what's happening within our own specific smaller area within the health sector in the sexual and reproductive health field. Within the SRH field, the anticipation is that there will be service disruptions, that staff, health providers will be transferred from the activities that they currently do, and that they will probably be directed to the pandemic response. And we are also anticipating that there will be barriers at the health user level. We anticipate that there are going to be disruptions in supply chains, that there are going to be stigma and discrimination and fear of infection that will keep users from going to health facilities. So within this context, what's happened in the last few weeks is that there has been a number of guidance documents being given by normative bodies, both at the global and at country levels. And I've listed a few here just to give you an idea of what these guidance documents, who these guidance documents have been coming from. More importantly, our advocates have been tirelessly advocating that SRH services be considered essential services and that SRH needs don't be ignored during the pandemic. Interestingly, this has also been a time for creative solutions to deal with the problems of lockdown and social distancing. In particular, telemedicine and self-care are being scaled up. There are lots and lots of experiments in a number of areas where these interventions are being picked up. And we are also beginning to see evidence coming from simulations about what the anticipated effects of the pandemic can be on reproductive health outcomes. Here, I do a shout out to colleagues from Guttmacher who have recently put out their analysis of anticipated effects. So it's within this context that we decided when we put this webinar together as to what specific or new theme we could surface during this conversation among ourselves. And we thought that clearly there's a role for data and evidence to fashion the responses to the pandemic. And with that notion in mind, we put together this set of panelists. Kristin will be talking about her paper that she wrote, where she talks about how you can combine data from service statistics as well as from community-based surveys, whether from DHS or mix, to figure out how to create a response. Over to you, Kristin.
Thank you so much. Thank you for inviting me to present our research today. This research was conducted by the Track 20 team, which conducts annual monitoring of the FP 2020 Global Initiative, as well as conducting research surrounding contraceptive use in FP 2020 countries. Next slide, please. The West African Ebola outbreak from 2013 to 2016 caused over 11,000 deaths and devastated the already fragile health systems of Liberia, Sierra Leone, and Guinea. Documented disruptions of health services included staffing shortages, quarantines, interruptions of supply chains, health facility closures, and fear of health facilities. Research has already found documented impacts on inpatient health services and surgeries, malaria treatment, vaccinations, obstetric care, and family planning. Next slide, please. Prior to Ebola, Sierra Leone and Liberia had made great strides in increasing family planning use. There was worry post-Ebola that they would not be able to meet their ambitious Family Planning 2020 goals, which prompted our analysis. As you can see here, Guinea had little change from the early 2000s to the period before the Ebola crisis. And I'm not going to talk about them today because at the beginning of the Ebola crisis, they had not yet implemented electronic data collection for their family planning distribution. Next slide, please. The research questions we set out to answer in this article were, how do complex emergencies like the West African Ebola crisis, which can have devastating impacts on the health systems long after the immediate crisis ends? So our research really looked at, how much did family planning provision decrease during the Ebola crisis? And then did the Ebola crisis have a lasting negative impact on family planning use in these countries? Next slide, please. We use data from 3 sources here. First, we use the World Health Organization's confirmed cases of Ebola, information from the District Health Information Systems, DHIS2, which were employed in both Liberia and Sierra Leone to collect electronic routine data, which I'll call SIR statistics, on family planning provision. This data is collected monthly at the facility level. And finally, because large-scale analysis using SIR statistics is limited in family planning, and many people worry about biases in SIR statistics, we include several nationally representative surveys, which serve as anchors to this analysis. Both countries had surveys immediately before and after Ebola. I use information from the demographic health surveys, malaria indicator surveys, which are conducted by DHS, and as well as the multiple indicator cluster surveys. Next, please. I focus on 4 main forms of contraception in this research: injectables, implants, oral contraceptive pills, and condoms, which in 2013 accounted for over 95% of modern contraceptive use in both countries. Because I want to talk about all methods simultaneously in this research to discuss the overall impact on declines in distribution, I convert these methods to couples' years of protection with the graph shown below, which show how long each method provides protection for a woman. Please. Next slide, thank you. This is a timeline for both countries for the periods of analysis. So you can see that each country has its own timeline when Ebola began and ended in each country. We then look at 6 months before the first confirmed Ebola case, and then 6-month intervals for 24 months after. We include these 6-month averages to minimize the impact of data heaping and reporting. We also look at the months during Ebola where there was the lowest distribution of family planning, and also the highest number of Ebola cases. And you'll see that in both countries, the lowest amount of family planning and the highest Ebola cases were within 1 month of each other. You can also see here the location of all surveys included. The DHS surveys were included 6 to 8 months before the start of Ebola, and then you have surveys near the end of the 2-year window. Next, please. Here we're looking at comparing surveys pre-Ebola to SIR statistics. We can see that between the 2007, 2008 DHSs and the 2013 DHSs in both countries, there were dramatic increases in family planning use. Especially growing were the use of injectables and the introduction of implants into both countries. Now you might notice that the yellow in SIR statistics is larger than it is in surveys, and that's because we're attributing all 3 couple years of protection to the individual year of insertion in 2013. In both SIR statistics and surveys, we can see that injectables implants were the major methods of use in both countries before Ebola. You might notice that the survey data shows an equal level of contraceptive use in both countries, while the number of CYPs is quite different. And this is because Sierra Leone has a larger population of reproductive age women than Liberia. When you take population into account, the CYPs per population is equal. Next, please. Next slide, please. Thank you. Here I have the 6 months before Ebola, the average in terms of couple years of protection, and then each individual method. The second bars are the average duration or average CYPs during Ebola, with the black dots indicating the lowest month of distribution. In Liberia, there were over 3,000 confirmed cases of Ebola and 9,000 in Sierra Leone. What's interesting here is that though Sierra Leone had more cases of Ebola, it had a lesser impact on the family planning sector. Liberia suffered larger declines in contraceptive distribution, both in terms of CYPs and individual methods. Overall, there was a 31% decline in CYPs in Liberia during Ebola, with the lowest month seeing 65% less distribution than before Ebola. In Sierra Leone, the worst month was only a 23% decline, And on average, distribution across the Ebola pandemic was only 5% below pre-Ebola levels. This is because family planning actually recovered to pre-Ebola levels 3 months before the last Ebola case in Sierra Leone. In Liberia, the methods most impacted was implants, which is understandable given the necessity for close contact with providers. In Sierra Leone, impacts also had the lowest single month decline, but an increase in implants towards the end of the pandemic means that the average distribution was near pre-Ebola levels. Next slide, please. Now we've extended this to 24 months past the main Ebola outbreak. We see that CYPs and almost all methods had a return to pre-crisis levels in the immediate 6 months following Ebola. In Liberia, there was continued increase in implants and injectables, and Sierra Leone saw an increase in implants over time. In summary, in Liberia, pre-Ebola average monthly CYP distribution was 11,000 CYPs. During Ebola, it dropped to 8,000 CYPs. In the last period, 24 months after Ebola, it was at 16,000 CYPs per month, a 39% increase from pre-Ebola levels. In Sierra Leone, there was an average 15,000 CYPs per month before Ebola, dropping only to 14,000 during, and rising to 19,000 24 months later, an increase of 27%. The greater decline in Liberia, with the smaller number of Ebola cases, speaks to the impact of keeping women from health centers. Next slide, please. Comparing our results with survey data, we see a reflection of growth in contraceptive use that we saw in SIR statistics. In Liberia in 2013, 21% of women were using a modern method. By 2016, this had increased to 31%. In Sierra Leone, women also had 21% use of modern methods. This increased to 25% in the 2017 mix. Again, we see this larger increase in Liberia than Sierra Leone. The original question of was Liberia going to reach their FP 2020 goal was answered, yes, and they actually set a new one after seeing the increase in contraceptive use. Next slide, please. I now want to talk about some differences in the world in family planning from during the Ebola outbreak to now during COVID-19. There have been several changes since Ebola. First, there's been an increased use of LARCs. A quick analysis I conducted looking at surveys from 2010 to 2015 and then 2016 to present showed a 6 percentage point growth in LARC use. Though this is still not a majority. LARCs are still not the majority of contraceptive use by women. We also are seeing more countries with high quality HMIS data. An example of this is that we use HMIS data as part of Track 20 to make the annual estimates for Family Planning 2020. We only include countries with high quality SIR statistics data. In 2014, 5 countries were able to use HMIS data for their FP 2020 estimates. In 2019, 18 countries did. There are some similarities that we expect between Ebola and COVID-19, including the redistribution of health workers away from family planning. We've heard from several of our Track 20 officers that family planning health workers are being moved to contact tracing in some countries. We're also seeing similarities in social distancing, unwillingness to go to facilities for non-life-threatening treatment. There are some differences which might impact the recovery. For example, there seems to be less community engagement now, or attempts to engage the community in the response to COVID-19, which has an effect on how service provision is guided by community preferences. We also may not expect the mass donor influx of funding to health services that we saw post-Ebola, which was able to focus on 3 countries, as every country in the world is now combating COVID-19. There was a major influx into Ebola countries with money to rebuild the health sector, including family planning. We even saw an increased distribution of condoms as a way to reduce Ebola transmission. And we don't expect that to happen during COVID-19. There's also potential for manufacturing, travel, and shipping restrictions. Ebola did not disrupt manufacturing of family planning services, but COVID-19 is. In Ebola, there was subnational distribution chains for Ebola equipment that family planning was able to follow. We don't expect this much delivery of supply chains in COVID-19. Next slide, please. Track 20 is actively monitoring family planning during COVID-19 as we reach the end of the FP 2020 Global Initiative. We are using our embedded monitoring and evaluation officers to provide information and resources to understand how governments are responding in relation to FP services. Some staff are being reorientated. We've had some MEOs moved over to COVID response. Some offices are telling us of cancellation or reduction of some services such as outreach and mobile clinics. Officers are working to engage with outreach providers, monitor supply chains, and monitor facility and provider availability more than they've done in the past. Engaging with outreach providers such as MSI and PSI on data and service provision, becoming more engaged in the supply chain on community distribution and pipelines, and actively attempts to use the health system infrastructure to attain real-time information on facility and provider availability. At Track 20, we're modifying our tools and approaches that we use for annual monitoring to be used more frequently, monthly. We're wanting to look at monthly reporting rates of data to make sure that high quality data is still reported into the health systems. We're also conducting modeling that supports advocacy for family planning services to be seen as essential to minimize disruptions in sexual and reproductive health, and estimating the potential impacts of contraceptive use when disruption channels are reduced. Next slide, please. I want to thank Studies in Family Planning for inviting me to present this research today, and I now pass the conversation over to Julia White. Thank you.
Thank you very much, Kristin, and thanks for sharing an important look back at all the lessons learned from the Ebola crisis. Then, as now, data is crucial to anticipate potential challenges and mitigate the effects of the pandemic. My role on this panel is to provide insight on what we as a collective have been doing and can continue doing creatively with data to support contraceptive security in the face of COVID-19. So let's dive in. Next slide, please. The Reproductive Health Supplies Coalition was established over a decade and a half ago to ensure access to a range of affordable, quality-assured supplies. Today, we are over 500 members strong, and we sit at the nexus of a host of diverse perspectives from the global supply chain to the country last mile, from those who are focused on ensuring funding and flow of supplies for tomorrow to those who are struggling with frontline service delivery today. But no matter which vantage point we take, everyone wants the same thing right now, a crystal ball. A crystal ball to predict the future and answer questions about what is the best way forward to ensure women continue to get the right products at the right time, and a way to be proactive rather than reactive. So the closest we have to this crystal ball is data. Data that allows us to try to predict and forecast what will happen due to different disruptions and how we adjust to minimize impact. Luckily, in the family planning community, we have a history of collaboratively using data to make important decisions for our community. Today, I will discuss 3 key collective data interventions that are going on under the coalition from different perspectives. So the supply need for the supply chain perspective, supply need from the user perspective, and new collaborative perspective. Next slide, please. Let's start with the supply chain or product perspective and look at our history of supply chain visibility and how we're leveraging it today. The COVID crisis has highlighted just how much we live in a complex ecosystem of trading partners spread across the globe, as you see here. We are all interconnected. Donors and countries who are procuring depend on manufacturers to have product, who depend on shippers to deliver product, who are impacted by country regulatory and service delivery decisions to get products in country and ultimately to women. At every stage of a product's journey through this ecosystem, decision makers need to see where the products are and answer key questions, like how many units to buy, how much to manufacture, which products to ship and when products will arrive. When the product is in short supply, we all have to work together on equitable distribution, given how interconnected we are. Insufficient, incorrect, or mislabeled data sends wrong messages through the supply chain, resulting in stockouts, overstock, expiration, wastage, and disruption. The right data at the right time is critical to keeping the supply chain moving. Next slide, please. Since 2004, the coalition and its members have been developing tools and groups to get the right data to answer these questions. The Reproductive Health Interchange was developed to tell us who had purchased commodities and how much. The PPMR, or Procurement Planning and Monitoring Report, tells what country stock levels are. And two groups, the Coordinated Assistance for Reproductive Health, the CARS, and the Coordinated Supply Planning Group, CSP, work with countries to respond to or better proactively prevent in-country stock imbalances. This is what you see on the left of this slide. While we had the people and the processes to tap different data sources in a timely way and make coordinated decisions, we were increasingly constrained by outdated technology, siloed and duplicative processes, and a lack of data standards. In the short term, to improve the upstream picture, we needed to move from split processes and the data sources on the left to the common set of processes supported by one platform that you see on the right. This is the starting point for the Global Family Planning Van. Next slide, please. The van went live last year in January 2019 and has become a significant data aggregator. Its power resides in being able to harmonize data descriptions, thereby integrating and aggregating supply chain inventory, order, and shipment data from across many different organizations in one platform. Let me show you what I mean. So as you can see here in the snapshot from the analytics dashboard, its current 100 users across 15 different organizations can track over 4,200 orders and shipments. That's circled in yellow across 135 countries, also circled for 30 products. And right away from this dashboard, you get a feel for the volume and value of products moving through our ecosystem. Those with the appropriate role security can drill down on these dashboard figures to understand how this plays out across each product, country, and procure. Next slide, please. The van has also become a key place for planners and countries to have a one-stop visual that tracks planned and incoming shipments against consumption and inventory to flag product over or under stock against the supply plan. As you can see in the screenshot, they can see the trend in consumption and stockouts over time against their request orders, and they can use the scenario builder in the platform to plan out their future orders. Next slide, please. With this data, we can also take a look at a snapshot of more aggregated data, like what is currently in transit and a confirmed order right now across all USAID, UNFPA, and any other member data shared, whether just for a single country or region or globally. On this side is a snapshot from the platform of the current in-transit and order reality at an aggregated level. This is updated in near real time. So what this is telling us is there are 102 shipments in transit for 18.7 million units of product totaling $8.78 million right now. There are also 383 confirmed orders in the queue for 661.5 million units totaling $104.6 million. Next slide, please. So that gives a flavor of the type of data and its use in the van. While the van data is good, it's actually at its best when combined with other data sources. So if we want to assess what are the most at-risk shipments and orders, it can be combined with COVID-19 demographic data, like the data listed here from Johns Hopkins University and the World Bank. Next slide, please. We can then align outbreak data with supplier manufacturer locations and shipment order data. How do we do this? Well, there are several different approaches, but let's explore one example. First, we could start by looking at COVID confirmed cases per country, location of supplier manufacturer. But this does not provide a sufficient view of the potential disruption of the supply chain. So we would need to layer in population density versus total population and the volume of confirmed cases to assign a relative risk percentage to the locations of manufacturers. These locations could be the most likely for continued and heavy disruption. If we then take estimated ship date per method and layer in the relative risk percentage per location for those methods, you can create this type of heat map, where it goes from the least risk in light yellow to the most risk in dark red. From this, we see that Q2 is a heavy quarter for getting shipments out to countries, and we can see what orders might be most at risk. It's important to stress that there are many factors that can go into potential disruptions and into simulating that. This is just one approach. We're currently working with members of the coalition to agree on a series of assumptions and approaches to use moving forward. Next slide, please. Let's now look at this from the user or program angle, and yet a different approach to modeling infection rates and potential disruption. One of the big challenges we face in trying to make sense of COVID-19 is how to balance the global supply chain challenges with the country realities on the ground. Not all countries find themselves in the same situation with regards to supplies or making use of the supplies they have. So just like the VAN supply chain data is crucial for predictive analytics, so is the commodity gap analysis data, with its insight to demographic data about method use by new or continued users, and product distribution in country. The combination of stay-at-home orders, overwhelmed healthcare systems, and concerns about interacting with providers all point to a likely temporary shift towards self-care methods. This could include contraceptive pills, condoms, patches, etc. What will ultimately be used will be driven by what product is available. We're right now analyzing this data in this context. It provides data risk modeling for the implication of changes to service delivery options and can be used to make recommendations. Next slide, please. Let's look at a scenario where users could potentially switch to contraceptive pills as a self-care option. New guidance from the Royal College suggests prescribing progesterone-only pills or mini pills as they have a reduced risk of counterindications. Therefore, it is possible that in the short term, we may be seeing large numbers of current users switching to pills. This, coupled with recommendation of advanced provision of 6 to 12 cycles, could lead to a surge in demand. What you see here is commodity gap analysis data used for a starting point with different scenarios modeled for the coming 6 months. Scenarios were based on minimal and high disruption to service delivery, with more switching to self-care methods under the high scenario. Advanced provision of 3, 6, and 12-month cycles was modeled. Based on different scenarios, this model estimates that across low-income countries, demand for contraceptive pills could potentially surge to between 2 to 5 times current consumption. Again, as with the VAN risk modeling, it is important to stress that there are many factors that can go into modeling. This is just simply one scenario. Next slide, please. The real power of this data is not necessarily in these two separate tools or in their two separate risk modelings, but rather in their combined analysis. We are entering a new world that entails a much more symbiotic relationship between what we've traditionally understood as global product supply chain and country program service delivery. Information from both worlds needs to be understood and analyzed for holistic recommendations that align across the product and program realities. We are inextricably linked, and supply chain recommendations that push quick placement of orders could potentially result in stockpiling up in a country that cannot be distributed. Alternatively, program recommendations that push self-care or switch to a certain type of product across the board could result in a supply chain that can't offer the supplies given the global market reality. What is needed is to look across the products and the program data together in combination to offer a more country-specific, nuanced view based on the risk analysis per country and the options. The good news is that we can do this with the data we have. We are looking to put the views together to do short-term risk modeling and propose holistic recommendations. Next slide, please. So based on everything I just said, there are 3 main points I want to emphasize. Now, more than ever, we must do 3 things. First of all, continue sharing data. We have over a decade of experience of sharing the data, and we must continue to get it from different perspectives to be able to do these analyses. 2, we need to build on our foundation of data collaboration. Despite the feeling of panic and crisis, it is not the time to respond too quickly within our silos, but rather to call on the collaborative mechanisms of groups like the Coordinated Supply Planning Group, the CARS, the VAN, and the coalition implementing mechanisms to work together, review the situation, and make joint recommendations. And finally, we must work synergistically and innovatively across the different dynamics of product, program, and global country. by looking at data together to make the holistic short-term recommendations. So with this in mind, a joint statement on the importance of family planning data sharing and collaboration is being disseminated as we speak. So if you see it on our website or otherwise, please do distribute this through your channels and partners. Thank you so much for listening. And with that, I'd like to hand this over to Johannes, who will offer some reflections on the discussion.
Thank you, Kristin, and thank you, Julia. Following these two presentations, which looked at the impact of an epidemic on service delivery and provided insight in global supply chain mechanisms for contraceptives and its vulnerability, I'd like to share some reflections with you. First, the COVID-19 pandemic is unlike any disease the world has confronted in over a century, in that it is a global event with unparalleled impact on health services delivery, supply chains, and the availability of commodities, and manufacturing, on the ability of individuals to move about freely, and thus affecting education, economic activity, and healthcare-seeking behavior. And indeed, with a severe economic impact, which is likely to have its greatest toll among our nations and the world's most disadvantaged. And the impact on sexual and reproductive health services will disproportionately affect women the world over. Second, we know from previous epidemics that the degree to which health service delivery is disrupted is on the one hand a function of the severity of the epidemic and influenced by stigma, social distancing, fear of exposure, and reassignment or illness of health workers. But on the other hand, it's also related to the resilience of the health system, its ability to continue to provide essential health services or to make use of alternative care and delivery mechanisms. It's important to note the role of the private sector in providing services and system resilience. Note also then that the family planning van collects both public and private sector data. Third, to help mitigate the impact of the epidemic on sexual and reproductive health and family planning and other healthcare services, we need data. Service statistics can provide near real-time information on service disruptions, which in turn could and should inform steps that can be taken in communities, facilities, by district health managers and ministries of health to ensure equitable continuation of essential services. A few were mentioned: shifting to and supporting self and home care, use of telehealth and mobile health solutions, and multi-month prescribing and dispensing, including community dispensing, will reduce the need for often lengthy visits to crowded health facilities. Of course, such solutions require supportive policies, which in many countries don't exist, and many health systems are poorly prepared to put such modalities in place at short notice. And that brings me to my fourth and last point. Data from service statistics, from health and indicator surveys and special studies will inevitably provide evidence of the impact of COVID-19 on health and well-being, including sexual and reproductive health and family planning use, beyond the morbidity and mortality directly associated with the virus. This information is invaluable in making the case for a sustained focus on and support for strengthening health systems, especially where the system interfaces with its users and beneficiaries, the primary healthcare system. The history of past public health emergencies is littered with examples of short-lived and insufficiently funded efforts to prevent or be better prepared for a future emergency. The world is already doing much to increase the ability of countries to detect, identify, and control outbreaks. And that's great, although we see now not necessarily sufficient. Parallel with that, we need to ensure health systems and service delivery modalities have the resilience and flexibilities to sustain essential services throughout the next outbreak, the next epidemic, or the next emergency. With that, I hand it over to Saumya for the Q&A.
Thank you, Kristin. Thank you, Julia, and thank you, Johannes. So questions will be coming in. They're trickling in from the audience. But before I read out the audience questions, I wanted to summarize the main messages from our conversation today. So the first message is that the global health field has had experience dealing with shocks to the health system before, whether it is Ebola, as we discussed today, or whether it was when the HIV/AIDS pandemic, the epidemic was rolling out. And of course, then there are the other ones, whether it is Zika and so forth. So clearly, the COVID-19 issue is now a pandemic, but we will have to respond not only on the supply side, but also address demand side barriers, especially stigma, which might hinder service utilization. So that was one message. And then the second one was that even though there is a health crisis, it's possible to build resilience and to rebuild once the outbreak or the crisis has passed, and which means that we will have to invest in health system strengthening, including supply chains and working across both public and private sectors. Thirdly, as this presentation demonstrated, there's a creative use of data and evidence to not only pinpoint areas of weakness, but also to suggest solutions. In both Kristin and Julia's presentations, we heard about the triangulation of data from the supply and the demand sides to figure out what the solutions would look like. So let me begin by reading out some of the questions that have come in. And give me a second. Kristin, this is the first question which has come in, and it's, I would think, a relatively easy one for you to answer, which is about, when you talked about Sierra Leone and Liberia, could you give a sense of whether they are of the same size and the distribution of the population so that people can understand how the numbers fit?
Sure. So Sierra Leone has 2/3 as many, or 2/3 more women of reproductive age than Liberia does. So when you take the CYPs and divide them by the population, they have roughly the same CYP per population before Ebola.
Okay, thank you. The next question would be for Julia, and let me read out the question as is, Julia. One of our audience members says that when you talk about changing the distribution of medicines, whether it's giving out 3 packs of pills to 6 packs of pills in terms of advance provision, that may not really reflect demand. All it means is that so many packs of pills were distributed, right? So if that's the case, we may not, it may not really reflect either the ability of the woman or her desire to use that particular product. But on the other hand, if there really is a surge in demand for any one particular commodity, could you comment about what supply chain issues that might arise?
Yes, thanks, Saumya. So this is exactly, one of the points I wanted to make, and why it's really important not to just look at the global supply chain or just look at these what could be service delivery analyses in silos, but rather to take it on a case nuanced analysis of what will actually be recommendations that are feasible both in the supply chain and in service delivery. So a couple of things about this question. So one, what some of the simulations are suggesting is that it would actually be a change in consumption if there are current users who switch over to actually using pills instead of other products that they were using because of the self-care. And so they would actually be switching and then consuming something different. The 3 to 6 month or 12-month quantities being suggested, that is correct, that would be for users who are already using it. And in that case, it's more about the placement of the product. But if you have current users who are switching methods, then that is actually switching consumption and what is being consumed. So I think the bottom line here is that if we go too far on the service delivery side of making blanket recommendations, we could end up with sort of a bullwhip effect where you're pushing all this product out based on one set of recommendations or based on what you're seeing on the supply chain. And you could get product piling up that then can't be distributed because the actual ability to consume isn't there. Or you could get a case where you're making recommendation for product that doesn't even exist from the manufacturer side. So you're recommending perhaps self-care options that aren't even really possible in terms of manufacturing. So the idea of the last couple of slides was to reinforce that either one of these data sets used on their own is potentially going to show a partial and potentially even false picture. It has to be the combination of the two to really look across and do some nuanced analyses of what's possible with the global manufacturing reality that we have, the shipping reality that we have, and the reality of frontline workers, what they can actually get into each country and get distributed.
Thank you, Julia, and thanks for reiterating the messages that from the presentation. Here was a slightly different question that came in, and this is asking about what was the response of donors to post-Ebola, as to what happened, what was the level of financing that was provided. The audience member especially asks about USAID's response post-Ebola, and should we anticipate a change in the US administration to minimize supply disruptions? Kristin, I think you would be best positioned to answer this.
Thank you. Yes, in the paper, I have a large section on discussion of post-Ebola financing from both USAID and DFID. Liberia received $73 million in maternal and family planning funding and $58 million for basic healthcare from USAID post-Ebola. And Liberia also received $16 million from the Global Financing Facility, GFF. It's interesting, USAID gave more money to Liberia and DFID to Sierra Leone, linking different colonial aspects there. So it'll be really interesting to see post-COVID how donors respond, especially USAID, given that every country will have needs for health facility financing. So it'll be quite different than the millions and billions in aid that we'll be able to direct to 3 countries post-Ebola. So I think that's a question for people at USAID. I don't know what's going to happen with the difference in administrations.
To be watched for sure. I'm going to make a slight change in tack here and direct a question to Johannes. This was an issue that several of us have been thinking about, which is what's going to happen in the safe abortion space. So Johannes, the question is, if you can share some insights on the impact of COVID-19 on access to safe abortion, both in terms of should we anticipate unintended pregnancies and also disruptions in supply of safe abortion commodities. So I think we can break it into 2 parts. Johannes, if you can answer, give your reflections on what we anticipate, especially about avoiding unintended pregnancies. And Julia, I'll bunt this to you about the work that the coalition is doing on safe abortion commodities.
Thank you, Saumya. Yeah, I think it stands to reason to expect that with reduced access to healthcare facilities, there also will be reduced access to safe abortions, which in turn may lead to unwanted pregnancies or unsafe abortions that lead to maternal death or the pregnant woman's death. So yeah, I think and the longer these service interruptions will last, the more likely it is that these events will accumulate and contribute seriously to the COVID-associated morbidity, mortality, or lack of well-being. And of course, we can only quantify that once we have better data on this. So it's safe to predict this. It's harder to predict just how big of a problem it will be.
Thank you, Johannes. Julia?
Thanks, Saumya. Under the NERD caucus, the coalition does have a work stream that works on safe abortion and is looking, generally even before COVID, is working on this topic. And so I think, Saumya, I will also bounce it back to you in that essence of there is opportunity and space within the coalition for those conversations to move forward. And I think one of the big questions that's always there that this group explores as well is sort of the ability to get the best data, knowing from sort of the barriers and policy side that sometimes we know that we don't get the best data from the population side. There is data that will come through from hospitals, but it doesn't represent the actual use overall of safe abortion and medicine, et cetera. So I will pass that over to you as well, Saumya, to speak maybe a little bit about the NERD side.
So within the NERD caucus of the RHSC, as Julia mentioned, we do have a work stream looking at how the disruptions might affect, how the pandemic will disrupt the supply chain for, especially for medical abortion drugs. On one hand, we are seeing an increase in telemedicine and guidance also from certain national authorities allowing for self-use of MA. However, if we are going to see our manufacturers unable to either manufacture or ship these products, it's likely to have some issues. There is a possibility, of course, that in those areas where health facilities are able to operate, you have access to MVA instead of MA as the way of uterine evacuation. I realize we're coming up on time, so I just wanted to ask one question and directed to Julia. Julia, a lot of the and perhaps Kristin, you can chip in afterwards too. A lot of it depends on the quality of data that we collect. What do we know about the quality of data, whether it's, especially when it's reported by a variety of different sources in the public and private sector, the one that you just alluded to? How do we know, how can we make decisions on data which may be patchy? So Julia first and then Kristin.
Thank you so much, Saumya. And this is an excellent question I've seen coming through here. I talked about in the presentation the over a decade and a half of the coalition, and a large part of that history has to do with supply chain visibility. So speaking first from the supply chain data side, we have a large history of working with the two groups, the CARS and the Coordinated Supply Planning Group. And one of the main things that these groups do from a technical assistance aspect is really working on the data and understanding the data quality and doing back and forth with the data providers. So I talked about the tools of the PPMR, of supply plans. These types of data sources coming in go through vetting processes and have for over a decade, and the VAN is making our ability to really improve the data validation processes and make them even more robust with countries. And so the more we build on that history we already have in the groups who are doing it and make it easier for them to interact with the countries, the better. And so I would say in our space in family planning, we do have a long history of sort of vetting, validating, cleaning that data to the best of the ability. That doesn't mean that all the data is perfect by any stretch. It depends on the source of that data and what we can learn about it in order to really make it link up and make it make sense. So I would say—
the last word for you.
Yeah, the advocacy point here would be that there should be, funding and effort put into the data and the data quality work, because this is central to sort of ensuring these predictive analytics can be as good as possible.
I think one of the challenges with family planning in general is collection of routine, high quality data. This is a challenge even not in times of crisis. Having overworked health workers also be in charge of entering data from a facility level is challenging. So this is even more challenging when we're going to see a strain on health worker capacity. So it's important for there to be support for entering data at the facility level and then monitoring of data at the national level or subnational level. In this research, we actually found a couple of data errors and had to go to the head of an organization in country of an NGO to find issues with that data to correct those problems. So I think that's something that's always a challenge in family planning, and even more so as people are being taken from family planning over to other efforts. It's going to be a challenge to really focus on quality family planning and provision, and then recording of that provision.
Thank you, Kristin. There are lots and lots of other questions that we were not able to address today, and we will try to answer these questions and send it back to the audience. Since we are almost at time to wrap up this webinar.
Thank you, Saumya. As you may know, the Population Council publishes 2 peer-reviewed journals, Population Development Review and Studies in Family Planning. On behalf of the editorial committee, I want to take this opportunity to announce that we're encouraging researchers to submit your COVID-19 related research to Studies in Family Planning. We welcome submissions in sexual and reproductive health, fertility, family planning, HIV, AIDS, abortion, maternal and child health, and related topics. And our primary focus is on developing countries. All articles that are related to COVID-19 will be open access, freely available to read and download. The journal will accelerate the submission process for COVID-19 papers by prioritizing their evaluation and review while continuing to conduct our usual peer review process. Authors of COVID-19 papers may choose to have the accepted versions of their papers published online to expedite dissemination. On the screen, you can see the URL for Studies in Family Planning, so please go and visit the site for further information. We also would love for you to get in touch with any questions that we couldn't answer today, or let us know what COVID-19 related work you're doing. Our email address is sfp@popcouncil.org. Next slide. I also want to call your attention to the Council's website, where you can read about and see the work we're currently undertaking related to COVID-19, and our Dataverse site, where we're posting data sets based on data collection efforts just over the last month or so, our study protocols, and our findings. And with that, I'll end the webinar. Thank you all very much for attending.